Hello and welcome back to Wellness Wednesday, where we share practical wellness tools and techniques from experts on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger, and I'm so happy to be back moderating this edition of Wellness Wednesday, where we're going to talk with Dr. Alison Klein, who's the Director of National Familial Pancreas Tumor Registry at Johns Hopkins, about the role of family history on pancreatic cancer. A few housekeeping items before we get started. Don't forget you can ask questions throughout the entire program through their chat. If you're watching us on Facebook, you can put it in the chat there. If you're watching us live on Zoom, you could put it in the chat here. We're going to keep all of the questions until the end to make sure that we could get to everybody, but we promise we'll get to your questions. Dr. Klein has a lot of great information to share, so we're going to jump right in. I'm going to let Dr. Klein share all of her impressive credentials, but I do want to share that her research focus is to identify the genes and environmental factors that cause pancreatic cancer and translate these findings into improved patient care and risk assessment. Welcome, Dr. Klein.
Thank you. It is a pleasure to be here today and talking with you all about pancreatic cancer. Let me share my screen. Hopefully that's live for everyone. If not, as Erin introduced me, I'm Allison Klein. I'm a professor of oncology at Johns Hopkins. I've been studying families with pancreatic cancer to understand why pancreatic cancer runs in some families, to understand genetic predisposition for over 20 years now. So I'd like to talk to you a little bit about what we learned and where things are going in the future, hopefully quickly, and how we can use this to lead to better detection and prevention of pancreatic cancer. So we always have to disclose things. In the past, I have consulted with Merck. So I want to start with an overview of pancreatic cancer and where we stand in 2021. Over the past 25 years, we've really seen a doubling of the number of pancreatic cancer cases diagnosed globally each year. In 2017, there are just 450,000 pancreatic cancers diagnosed worldwide. And this is doubled from about 25 years previously. Why is that? Age is kind of the driving risk factor for this. Fortunately, life expectancy worldwide continues to increase. And the downside of that is there are more pancreatic cancers diagnosed mostly because people are living longer. In addition, when we kind of control for these age factors, we've also seen that the age-adjusted rates have increased. Not quite as much. So they've moved from about 5 per 100,000 person years to about 5.7. So in the United States, pancreatic cancer is currently the third leading cause of cancer death. It's projected to be second by 2030. In 2021, there will be about 60,000 new cases and about 48,000 deaths due to pancreatic cancer. The good news is we've seen more pancreatic cancers diagnosed earlier, so an increase in the early stage disease and an increase in the 5-year survival rate up to 10%, where it used to be 5%. So yes, we've made strides, but we really have a long way to go. If we look at pancreatic cancer kind of in the United States, risk is highest in Black Americans and at about 5.5 per 100,000 annually age adjusted, and about 11.2 in whites. Unfortunately, Black pancreatic cancer patients who are Black were less likely to receive kind of treatment according with national guidelines. Therefore, they have a lower median survival. And we really don't know a lot about risk factors across different populations. Are there different risk factors? Do the effects of risk factors difference? But we're starting to do a lot of those studies. So what do we know about pancreatic risk factors other than family history? I'm going to spend a lot of time talking about genes and family history, but I kind of wanted to put this in the context of what we do know and the things we can do now. So we do know that cigarette smoking, current smokers have about twice the risk of pancreatic cancer than never smokers. So it's really important to kind of think about cutting back or quitting smoking, the good news is risk after you quit goes down in about 10 or 15 years after smoking. Quitting smoking, the risk in former smokers equals that in never smokers. Obesity is a growing risk factor for pancreatic cancer. There's about 60% higher risk in obese individuals than normal weight individuals. The increased prevalence of obesity in the US is kind of one of the reasons why we're seeing more pancreatic cancer. Alcohol use, particularly very heavy alcohol use. So these are individuals who drink 6 or more drinks per day, have about a 60% increased risk of pancreatic cancer. Diabetes is both a risk factor and can be a symptom of pancreatic cancer. So we often split this up and talk about individuals who are recently diagnosed with diabetes versus those who have longstanding diabetes. So a new diabetes diagnosis can be an indicator of an underlying pancreatic cancer. However, only less than 0.5% of newly diagnosed diabetes have it due to an underlying pancreatic cancer. So most diabetics are true diabetics, but a fraction of them develop it because of an underlying pancreatic cancer. However, this might be an opportunity for earlier detection, and there are large studies funded by the National Cancer Institute to really explore these. Also, this risk of new onset diabetes does vary by age and race and time since diabetes diagnosis, with most pancreatic cancers diagnosed very quickly after that diabetes diagnosis, such that, when you get to be 6 months or a year out, the risk is much lower than it was immediately following that diagnosis. Also, long-standing diabetes, so these are individuals who've had diabetes for more than 3 years, are at about a 50 to 100% increased risk of pancreatic cancer. Individuals with pancreatitis have about a doubling of risk. Interestingly, allergy seems to be possibly protective, with individuals with allergy having a lower risk. And then finally, I'm going to talk about family history a lot in the coming slides. So, one of the reasons I study families and genetic predisposition is with the goal of identifying high-risk populations that hopefully inform screening and detection for pancreas cancer. And we often get asked, why don't we have screening tests like we do for breast cancer or colorectal cancer? And, we know that from those cancers that screening is really effective because survivorship rates have gone way up, but by their ability to capture early stage disease. So the challenge is pancreatic cancer is rare. It is one of the challenges to screening. If we take 200 US whites over the age of 65 and we follow them 10 years into the future, only one of them will fortunately develop pancreatic cancer. However, that means we have to have almost a perfect screening test so that we don't identify individuals as false positives and do invasive procedures when they're not going to go on to progress to disease, particularly for disease like pancreatic cancer, where the treatment or the interception is kind of surgical resection, which has its own morbidity and mortality associated. We talked a little bit about these risk factors. As we look at these risk factors, they then change kind of the denominator. They change, we focus in on a narrower population that has a higher risk, and we have the ability to detect more cancers. If we take 200 current smokers and US whites at age 65 and follow them 10 years in the future, now 2 out of 100 go on to develop pancreatic cancer. So, we are able to go in with a screening test and detect more cancers, but also the false positive rate, the risk benefit ratio starts to shift a little bit. So why genetics and family history, and what do we know about it for pancreatic cancer? So the identification of pancreatic cancer susceptibility genes can aid the earlier detection and lead to targeted therapy for pancreatic cancer. So cancer itself is a fundamentally genetic disease where we have a normal cell that becomes a cancer cell through a series of genetic and then larger genomic changes. So first you get changes to the DNA. You can also get additional changes such as methylation that change how a cell functions. It gives it a growth advantage, and then that transforms into the cancer. So I'm going to talk a lot of where my research focus is on inherited germline genomics. versus, so inherited variants versus acquired variants. You hear a lot now about tumor testing, tumor sequencing, and that was really focused on detection of somatic or acquired variants. So these are changes in the tumor that are different from that person's kind of normal DNA that they're born with. So it's acquired over the lifetime. It's in the cancer cell, not in the rest of the body typically, and these variants are not passed on to offspring. If we think of germline genomics, and these are what are tested for through some of the hereditary cancer panels that are offered by various germline genetic testing programs, this is the changes that are in someone's kind of normal DNA. So it's present in every cell in the body, and it is passed along to children. The challenge with this is with a somatic change, that change is not in that person's normal DNA, it's in the tumor. It's very clear to understand, that is a change specific to the tumor or to the precursor that develops into a tumor. With germline genetics, we are all different. We all have genetic variants that make us unique. Most of those are kind of not associated with any particular disease or any particular phenotype. They affect hair color, eye color, and height, all of those factors, and really disentangling, finding a variant, understanding what it does is particularly challenging. We know so much more than we did 10 or 15 years ago or 20 years ago, when we didn't even know the number of genes in the genome before the Human Genome Project was completed. But we're really just trying to understand what normal genetic variation is, and then to identify what is disease causing on top of that. So often, much of what I study is familial pancreatic cancer. So these are families where there is a strong family history of pancreatic cancer. If there's just a single first-degree relative, so if your parent or a sibling has pancreas cancer, you're thought to be about twice the risk. We talk about familial pancreatic cancer kindreds or families. So these are families where there are two close relatives with pancreas cancer, so a parent and a child, or two siblings. The relatives in those families have about a 7-fold increased risk over the general population, and this risk is thought to increase with more family members. So the more enriched it is, the higher risk we see. So what do we learn from studying families? By studying the family history itself, we can understand the risk of cancer in the families, understand future risk. We can collect biomarkers for biomarker-based studies. We can look at clustering of other cancers, and using the DNA from these families, we can identify susceptibility genes, understand the risk of cancer in those with the susceptibility genes that when we do find them, and look for kind of gene environment interactions as well. So does the gene do the same thing in smokers and non-smokers? So right now we have just under 8,000 families in our registry. Our registry is 25 years old, so we've been studying families for a long time, and we continue to follow up and keep in contact with them annually. So many of those fall into our kind of our non-familial kindreds or sporadic, where there's just one pancreatic cancer or two pancreatic cancers and more distant relatives. We do have just over 2,000 families with multiple pancreatic cancers. Unlike, oftentimes you hear very large families with breast cancer or colon cancer when there's 5 or 6 affected members. We don't have a lot of families that are that enriched for pancreatic cancer, often because even in its familial form, it's not a disease that develops until the 6th, 7th, and 8th decade of life. And so we're seeing more families with more clustering as kind of life expectancy increases. When we look at risk of other cancers in these families in our registry, so we see that overall our families have about a 50% increased risk of cancer outside of the pancreas. Some of this is an increased risk of breast cancer, particularly in those in our familial kindreds and in those who are relatives of an early onset pancreatic cancer case, so a case less than 50 years old. We've seen increased risk of ovarian cancer, colon cancer. Interestingly, we also see an increased risk of bile duct cancer. There are some genes that we know that underlie both of these. conditions, but there's a lot of unknown susceptibility as well. So the risk due to family history of pancreas cancer, as I mentioned previously, if you have one relative, it's about twofold. If you're a member of these familial kindreds, it's about sevenfold. And if you're a member of these kindreds and you have 3 or more relatives, it's about 17-fold. So why is family history or variant status used for pancreas cancer risk modeling? Again, if we go back to our 200 families at age 65, if they have one family member with pancreas cancer, there's about a 7-fold increased risk if they fall into this familial kindreds. If they're a BRCA2 mutation carrier, I'm going to talk about BRCA2 in a minute. We see this enrichment so that, once we start getting to these larger numbers where we are more likely to find individuals with disease, the risks and benefits of screening start to shift a little bit. And we're able to kind of go in and start to learn how to screen in these populations, with the hope is if we can successfully screen a high risk group, then we can move down to lower risk groups. So as I mentioned, BRCA2 is one of the genes we know is involved and increases risk of pancreas cancer. This is most notably associated with familial breast and ovarian cancer. About 17% of patients with 3 relatives with pancreatic cancer have germline BRCA2 mutations. This is about 12% of patients with 2 relatives and about 6% of patients with a single relative with pancreatic cancer. Now, interestingly, this is not limited to patients with a family history of pancreatic cancer. About 5 to 7% of patients with sporadic pancreatic cancer have germline BRCA2 mutations. That was an early study done at Johns Hopkins about 20 years ago. A larger study has shown that about 5% or 4.1% of Ashkenazi Jewish patients harbor a specific founder mutation that is in increased frequency in that population. So about 4% of Ashkenazi Jewish pancreatic cancer patients have this particular 6174del mutation. And BRCA2 carriers have about a 3.5 to 6-fold increased risk of pancreas cancer. Mutations in the BRCA1 gene have also been associated with pancreatic cancer. Interestingly, the risk does not seem to be as high as it is for BRCA2, nor do we see these as common. So it's 1% or less of pancreatic cancer patients harbor BRCA1 mutations. Familial melanoma caused by germline mutations in the P16 or CDKN2A gene is associated also with an increased risk of pancreas cancer. Pancreatic cancer is the second most common cause of death in these large melanoma kindreds, and they're thought to have somewhere between a 9 and a 38-fold increased risk of developing pancreatic cancer and about a 70% lifetime risk. Why are these like such a big range, 9 to 38? Oftentimes these families are really rare, and even though they are at increased risk for pancreas cancer, they also have a lot of melanoma and other diseases. So because these studies tend to be small, there's a lot of uncertainty around the estimates. Families with Lynch syndrome or hereditary polyposis non-colorectal cancer, most notably, are also at an increased risk of pancreatic cancer, about a standardized incidence ratio of about 8 to 9-fold, so about a 9-fold increased risk of pancreas cancer. Individuals with hereditary pancreatitis, which is kind of a different mechanism. The genes I talked before are all cancer predisposition genes. Hereditary pancreatitis is caused by mutations in the PRSS1 gene, as well as some other genes. Many of these patients have kind of a long history of pancreatitis, particularly in the severe PRSS1 hereditary pancreatitis cases. They have a long history. They might not have a lot of pancreatic function, and 40% of these patients go on to develop pancreatic cancer. There's some other genes, CPA1, CPB1, that have also been associated with pancreatitis and pancreatic enzymes. And these variants might also have a slightly increased risk of pancreas cancer. So while I'm going to talk a little bit later about genetic testing for pancreatic cancer, but particularly if you've had a history of pancreatitis or a family history of pancreatitis, it's important to kind of think about these genes, and some of them aren't always on a hereditary cancer panel. So it's important to kind of consider these as part of testing. Another gene, once again, a hereditary cancer gene, is PALB2, which is a partner localizer of, it works with BRCA2. Together they form and repair DNA. When we did a large sequencing study of we started looking at, we did a whole genome. In our first studies where we did whole genome sequencing of pancreatic cancers, we included 5 familial pancreas cancer patients, and one of which had a germline variant in PALB2. This was the first example of using whole genome sequencing to find the cause of a hereditary disease. We then looked at 96 additional familial pancreas cancer patients and found 3 additional PALB2 mutations. These have been replicated in other studies, but it's only about 0.5% of pancreatic cancer patients have PALB2 mutations. And finally, we also identified that germline mutations in the ATM gene are associated with pancreatic cancer. So we see these in about 3 to 4% of pancreatic cancer patients have germline ATM mutations. We recently completed a study to look at what the risk of pancreatic cancer is in these families. So in family members of pancreatic cancer patients who had an ATM variant, what is their relative's risk of pancreas cancer? So it is strongly kind of age dependent. It's about 6-fold greater than what we see in the individuals without the mutation, and it goes up to about 10% risk of pancreatic cancer by age 80. Why is this important? ATM we weren't really sure how to manage these families. Should we be screening them? Are they at lower risk? So this really suggests that ATM is one of the higher risk genes for pancreatic cancer. So here's just a summary of kind of where we stand. And I talked a lot about how we found these genes by studying these enriched families. We then did studies looking at, do we see them in patients without a family history as well? So what we see is many of these genes, the prevalence of them, what percentage of patients have a mutation, is much higher in those with a family history compared to those without a family history. But still, it's a sizable fraction of those without a family history who also have kind of underlying mutations in these genes. And this is really important knowledge for their family members, who can go and think about screening, not only for pancreatic cancer, but also for other cancers. BRCA1, BRCA2, PALB2 are associated with breast cancer. The mismatch repair hereditary polyposis genes are associated with colorectal cancer. So it's important to consider for that as well. And that's really leveraged changes in the guidelines over the past couple of years. In addition, we're also starting to learn how to treat these particular cancers better. For example, large clinical studies have shown that PARP inhibitors might be particularly effective in BRCA mutant pancreatic cancers. One of the early immunotherapy studies showed that patients with mismatch repair, so in this hereditary polyposis syndrome, responded very well to treatment with some of the earlier immunotherapy drugs. So again, we're finding these targeted treatments, we're finding these mutations in some families that can inform better screening studies. So if we look at the distribution of pathogenic mutations in pancreatic cancer patients, we see that we know the cause of about 20% of patients with a family history of pancreas cancer, but it's still 5 to 10% of those without a family history. So it's important in both groups. It's just enriched in the familial setting. These studies really prompted kind of changes to guidelines within the past couple of years, so that now germline or hereditary genetic testing is recommended for all newly diagnosed pancreatic cancer patients, or now even their family members if that patient was not able to get tested. So And there's, we always recommend kind of genetic education and germline and genetic counseling prior to testing. Many of these companies now offer kind of large scale hereditary cancer panels that are, compared to where we were several years ago, more reasonably cost, such that, it's somewhere between $200 and $300 for these genetic tests. But with the insurance and these guidelines now that it's recommended for care for particularly in patients as well as relatives, hopefully insurance companies will cover the cost. Now within these, as I mentioned, many of these panels contain 20 or 30 or even more genes, some of which we know are associated with pancreatic cancer, those I've mentioned. There's other genes on these panels where there's more limited data. We're really not sure of their association with pancreas cancer. So right now we're not screening those families as well. But we're doing more studies to really understand, are these really high risk genes, or are these just kind of passengers along the way? Maybe some of them are associated with other cancers. But as I mentioned, the majority of familial pancreas cancer is still kind of unexplained. So we're actively looking for the genes that underlie that other 80% of families I alluded to, and also probably play a role in those without a family history. So if we think of kind of the genetic spectrum of disease, a lot of what I've been talking about are, as what we geneticists call, a rare allele causing Mendelian disease. So there's genes where there's a definite pattern in many of the families, and they're uncommon in the population, fortunately. Many of these tend to have a strong effect on the disease. So kind of, as I talked about odds ratio, these are all effect sizes. So how many fold greater risk someone with the mutation is versus those without it. On the other end of the spectrum, there are common variants. So these are variants that are present in 40, 50, even more percent of the population. They might have a very small impact on disease. It's important to find them and study them because they can teach us about why pancreatic cancer and other diseases develop. However, individually, they're not particularly prognostic. Because there are many of these, some of which, and so they're common in the population. You can put them together to do scores, but right now they're not really moving people to a kind of a higher risk families, higher risk category. So for high risk genes, what we're doing is we're doing a lot of kind of whole genome sequencing. The early studies using this approach enabled us to find PALB2 and ATM. So several years ago, we did a larger study where we sequenced 638 familial pancreatic cancer patients in 539 families. These came from multiple institutions, so not just Johns Hopkins, but Mayo Clinic, University of Toronto, as well as others, Memorial Sloan Kettering. Most of these families were kind of Caucasian or European ancestry. Many of them we tried to enrich for as much pancreatic cancer as we could. Why these studies are challenging is, most individuals have millions of genetic changes compared to a kind of standard reference. And so kind of disentangling what is associated, that one change that's associated with pancreatic cancer versus the other changes that make us unique is the challenge. We focused on genetic changes that caused basically a non-functional protein. Most of the mutations that are associated with hereditary cancer syndromes kind of fall into these. And we looked for genes that were frequently had, more than one mutation in this gene across patients. So 2 patients with a BRCA2 mutation or multiple patients with a particular mutation in a particular gene. And what we found is that most of these kind of truncating mutations that were rare in the population, we saw in 1 or 2 patients. So we didn't see a gene that seemed to be implicated across a lot of the families, making it really hard to identify, which of these genes and genetic changes were associated or at high risk. So we found that pancreatic cancer, familial pancreatic cancer, is really heterogeneous. And we're still uncertain as to the cause of most of it. So we need to do kind of larger studies. We need to understand these genetic variants better. There are larger initiatives going on now by sequencing more families. And also we're learning, the field of genetics is moving really quickly. Our ability to kind of interpret genetic changes is constantly changing. And as more larger scale sequencing studies of other diseases kind of go on, it also enables us to interpret what we see in our pancreatic cancer families even better. On the other end of the spectrum, so I've talked a lot about how we're finding these high risk genes. We're also doing large studies to look for common variants. So how these studies are done, they're called genome-wide association studies. You take a lot of people with the disease, you compare it to individuals without the disease, and you look for variants that are more common in one population than the other. And once these reach a certain degree of statistical significance, we call these Manhattan plots. So the very, very tall buildings that cross this line are the regions that are associated with disease of interest at a very high statistical level, suggesting that they may be associated with disease. So we've done to date for pancreatic cancer, we lag far behind other cancers in terms of the numbers of cases and controls we've examined, where we have about 9,300 cases and 12,000 controls. We have found several regions indicated by these skyscrapers that are associated with pancreatic cancer risk. We're now doing a study where we've brought together many of the existing kind of studies that have pancreatic cancer patients and controls, whether they're hospital-based studies, whether they're kind of large population studies that have followed patients into the future, and some of them develop pancreas cancer, to really triple the sample size of the study and hopefully kind of add more regions so we can begin to understand better what these regions are and to kind of move that forward. Here's just a list of some of the variants and the statistical significance. So it's important to kind of understand these, to understand the genetic basis of it, but I also want to often kind of give a note of caution. So a lot of the, in the contrast to the hereditary cancer panels testing, these genetic variants, these are often kind of captured in some of the genetic tests you can get on Amazon, or the 23andMe tests, Ancestry.com. So some of these also capture disease variants, these kind of array-based tests, as they call them. Many of these variants kind of individually cause a very small increase. So, before I was talking about a 5-fold or a 6-fold increased risk, here we see things that might have a 10 or 10, maybe a 40% increased risk. If you take, for example, one of the first hit identified by GWAS for pancreatic cancer is variation in the ABO blood group. Individuals with a non-O blood group are at a slightly higher risk of pancreas cancer than other blood groups. It's interesting, we don't really understand the mechanism, but it's not at the point where we can start screening people based on blood group. It's just, it's a very slight increased risk. So again, these individually really don't kind of move this bar from identifying one case much beyond that. You get a little fraction of a case. Even with you kind of do these collective scores, they don't really move people very far compared to what our higher risk genes do. And here's kind of just a schematic of what we know with the very high risk genes, which we can test for using these hereditary cancer panel, which are actionable. These other genes that we continue, or genetic variants that we continue to study, we want to understand more. And maybe if we put all of this information together in kind of a more intelligent risk model, we'll eventually be able to identify and stratify risk a little bit better. So future studies are to find these rare variants as well as common variants. We're also doing studies to really increase representation in our studies of pancreatic cancer. As I mentioned previously, African Americans have a higher risk of pancreas cancer. about 10% of US pancreatic cancer patients are Black. This number has increased tremendously since 2007. There have been very few studies of pancreatic cancer in this population just because we haven't had enough individuals to be included in studies. I'm leading a new study where we've pulled again from all of these different sites samples that we do have to really do whole genome sequencing of African-American pancreatic cancer patients to really understand, are there differences, and to aid kind of gene discovery to unlock, to understand pancreatic cancer genes better. We also are doing lots of studies to kind of improve early detection, I would say. So my research is really focused on kind of identifying high-risk groups, but I'm going to talk quickly about some of the better screening tests, hopefully that will be out there and on the horizon as we learn more about these diseases. So currently, the US Preventative Task Force does not recommend pancreatic cancer screening for the general population. They do suggest, could consider screening in high-risk groups, such as those with a family history of pancreas cancer, individuals with pancreatic cysts. I would say the kind of the general recommendation is if you are going to be screened due to a family history, make sure it's done as either part of a clinical trial or at a center that has a lot of expertise in pancreatic imaging or in pancreatic early detection. While we absolutely want to detect pancreatic cancer early, once lesions are detected, interpreting that data is really difficult. The decisions on when to operate versus not is challenging, and you really want surgical expertise as well. If you put it in context, even at the best centers, the surgical mortality from pancreatic resection is 1%. So that you don't want to get it wrong and be taking someone to surgery who does not have an underlying pancreatic cancer or will not develop it, because that also has kind of very severe downsides as well. So we really have to get this right. So the kind of the goal is we have our general population, whether it's germline factors, cysts, other risk factors, we kind of identify this high risk population, and then we're able to distinguish using genetics or other screening-based tests on who we want to intervene with. One of the areas I think is really exciting, not just for pancreatic cancer, but all pancreatic cancer, is the studies now of kind of circulating tumor DNA. So this is DNA from a tumor. Oftentimes these are the somatic mutations I talked about earlier that occur in the tumor DNA. There are certain genetic changes that are very specific to different cancers. Sometimes this cancer DNA gets shed into the blood, mixed with all the other blood in your body, but there's fractions of normal DNA and very small percentage of tumor DNA. And we're now looking at blood tests that will be able to detect this low level of tumor DNA in the blood. And hopefully this can be a blood-based screening test for cancer. The challenge is, when a cancer is very small, when it's still the amount of DNA shed into the bloodstream might be very small. We looked at this specific for pancreatic cancer using a combined kind of circulating tumor DNA plus protein biomarker test. And what we saw was, we can detect these cases in blood. If we look by stage of disease, our ability to detect it increases with more advanced cancer. But again, if we look at just stage 1 and 2 disease, we were able to kind of detect a fair number of these cases specific for pancreatic cancer. So this was a pancreatic cancer specific test. Then there was a larger test developed out of Johns Hopkins called CancerSeq, which combined this for all cancers. They did a study looking at this test in 10,000 healthy women. So these are women who did not have cancer. They then gave them this test. Within this population, they detected 96 cancers. 26 of them were first detected by this blood test. Some were detected by kind of standard of care screening, some mammography, colonoscopy. But in this population, there were only 2 pancreatic cancers. Neither were detected by CancerSeek, but it did seem to work well for some of the other cancers, and larger studies are needed for pancreas cancer. It's very hard to tell, out of those 2 cases, would it be able to detect some of them? And even, the good news with this study is in these healthy women, they also thought they didn't have a lot of false positives, which is always a concern with these population screening tests. So that was the good part of it. It did detect some cancers. We really need to know and do larger studies to determine if it's useful against pancreatic cancer. There's also other companies, Grail has a test as well that might be useful in this space and help to kind of distinguish between the 2. We have also been doing imaging-based studies. The CAP study is one out of Johns Hopkins that's been going on for quite a while, but other sites also have imaging-based studies as well. So they're doing endoscopic ultrasound in individuals with familial pancreatic cancer patients or germline mutation carriers. They start at age 55 or 10 years younger than the pancreatic cancer patient. Why this age? It's because really prior studies have really shown that there's that screening before this age doesn't really capture additional cases. And this is imaging-based screening, and there is biomarker development that's going along with it. What we've learned from this is that we do, when pancreatic cancers are detected as part of surveillance, they're caught earlier. There's an overall longer survival of these patients. So we are seeing longer survival after diagnosis in cancers detected as part of the screening study. So hopefully a really important step in that direction. All of the research I do is really a large kind of collaborative team. There's many individuals who aren't even on here who kind of contribute to it. I think one of the great things about pancreatic cancer research is we are a very collaborative group and we work together. And I think that's really enabled us to move further over the past 10 years, and hopefully we'll see a lot of progress within the next couple of years. For questions, here's my email. My research registry is the National Familial Pancreas Tumor Registry. There is our website and our email address at pancreas.jhmi.edu. You can reach me or my coordinators, and I'm happy to take any questions.
Oh, thank you. Pause here for a second because there's a lot of information there. A lot of questions have come through. So I'm going to ask a few that are to kind of re-summarize some of the data information you presented.
Sure.
So let's start off with the difference between inherited genetics versus acquired or somatic genetics.
Right. So, we are all born with 23 chromosomes made up of lots of base pairs of DNA. And there is kind of normal genetic variation. That's why we all, look different. And so that's kind of what we're born with, and our cells use this to make proteins to kind of function normally, to repair, there are error correction methods for DNA. But throughout our lifetime, we acquire genetic changes, whether this is kind of, a simple case is kind of melanoma or skin, sun damages your DNA. Smoking also damages your DNA. Also, just kind of the aging process, these normal changes happen. So in a cancer cell, cancer is developed kind of through these series of acquired genetic events. Oftentimes, they can affect the same genes as someone with an inherited variant. So in inherited cancer, someone's born with a genetic change that puts them at increased risk of cancer. In the sporadic case, it's kind of an acquired event. So the same genes can be hit in both times, but you need a series of events to develop cancer. It's just individuals with an inherited predisposition are kind of further along that line at birth and therefore have an increased risk of developing it in their lifetime.
Okay. So if it's there, then it's there, but it's a matter of if or when it grows into something.
So you have to have, you don't just need one, you need a series of them. So
Okay.
a series of these events in the same cell that then changes how that, it gives that cell a growth advantage and it progresses into a cancer. So it changes that cell from a normal cell into a cancer cell. So it's not just one, it's a series of events. So for example, yeah.
Okay.
I'll take it in there.
Okay. How about the difference between germline and somatic testing?
So somatic testing tests for the DNA, tests DNA in your tumor. So oftentimes, not every company, but many companies, you also have some normal DNA and some tumor DNA, and they're able to kind of detect the changes from that normal in tumor. So they look for differences between tumor and normal DNA. Many of these, sometimes these are actionable with particular treatments and targetable. For example, I talked about BRCA2. Some people are born with a mutation in BRCA2. Some people acquire it kind of somatically through their lifetime.
Mhm.
So oftentimes, somatic testing is really geared towards the tumor. Much of it are these acquired changes. Depending upon the company and how they do their tests, they might also kind of comment, that we see a BRCA2 mutation. It could be germline in nature, something along those lines, but they don't always capture all of these kind of inherited changes. For them, it's kind of these hereditary cancer panels that a lot of the genetic testing companies are now offering.
Okay.
Mm-hmm.
So this one's more specific. I had 3 family members die from pancreatic cancer. My mother had pancreatic cancer, but her testing didn't show anything. Do I need to worry?
So in general, if you still have a strong family history of pancreatic cancer, you are still thought to be at increased risk. Your risk is not the only condition, if your mother was known to have a mutation and you didn't have that mutation, then you're thought to kind of go back to population risk. But if you have a strong family history, it's always recommended to kind of talk to a genetic counselor or kind of someone who has experience in managing kind of familial kindreds, because there is this whole section of the genetic predisposition that we don't know and we don't understand yet.
Sure. And for those watching, I would encourage you to go back to last month's Wellness Wednesday, where we talked to Dina Goldberg from Dina DNA about genetic testing. So go ahead, it's on ralphfoundation.org and on our YouTube channel as well. And these will pair very nicely together. On the testing front, you had said something along the lines of if you're getting screened, you want to be a part of a trial. So can you explain the difference between genetic screening and testing? Is there a difference?
So I was talking about like imaging based screening or screening for early changes in the pancreas. Okay. So genetic testing, there's many routes there right now, whether it's some companies are doing not quite direct to consumer because they have physicians who work with them who order tests, such as Color Genomics, Invitae, also has options. So those are kind of genetic tests. So I'm talking about kind of detection studies. So whether it's, an imaging based study, most commonly their MRI, their endoscopic ultrasound, those studies, we recommend it, it doesn't have to, we recommend clinical trials or at a center of excellence. So, having screening done by someone who doesn't have expertise in kind of early detection screening for pancreatic cancer, there's kind of always the risk of more false positives or more false negatives. So the general consensus guidelines are to do it at a center where there's expertise.
Okay, that makes a lot of sense. And going back to the when you should get tested or the earliest, so that 55 mark is pretty standard across the board.
So that is there was a kind of consensus conference kind of worldwide of experts who screen for pancreatic cancer. And that was kind of the consensus, or age 55 or older, or 10 years younger than the youngest pancreatic cancer in the family. So if, an aunt had pancreatic cancer at 60, they would start screening the relatives at age 50.
Okay. And is it for children, is it worth having them tested just to see what they're carrying?
So this is kind of an area that's very controversial, whether you should be testing, children. I think in general, if it's an adult onset disease, it's kind of recommended, waiting until adulthood until that individual can make their own choice about whether or not they want genetic testing or not. There is laws in the United States that protect against discrimination for health reasons, for health insurance for genetic information. However, there are, considerations regarding other types of insurance, long-term care insurance, life insurance. So all of these, it's important to know kind of the risks and benefits and make individual level decisions about whether you want that information or not.
Sure. Okay. How about clinical trials that are going on right now? Do you have a list of trials that are happening, or where people can get their screenings done?
So I would say clinicaltrials.gov is a great resource for screening trials, and that's that spans everyone. I know we have the CAP study that continues to go on at Johns Hopkins. It is a multi-center study with we have a lot more sites more northeast, Pittsburgh as well, Case Western. But clinicaltrials.gov is a great place to go. If someone isn't near a clinical trial site and is wanting to be screened, but wants to know of someone locally who has expertise, always happy to talk to them and point them in the right direction of who, is expertise in a particular region of the US. Mm-hmm.
That's great. We'll put that in the chat as well, the link to that. Let's talk now. So we've long known that the risk for Ashkenazi Jews had been high for pancreatic cancer. It seems that Black Americans are now at a higher risk. Is that
so?
Or is it?
So of all of Black, white, Asian in the US, Black Americans have the highest risk of pancreas cancer. I think we don't understand the reasons for that. Ashkenazi Jews, there are some studies that are very old. I think we're going back to 20 or 30 years that showed that they had a higher risk. Now, some of that has to do with the fact that BRCA2 and BRCA1 mutations are more common in Ashkenazi Jews, such that about 1 to 2% of Ashkenazi Jews have germline BRCA1 and 2 mutations, whereas if you go to a European non-Jewish population, it's probably closer to 1 in 10,000. So part of that might explain the differences. I haven't seen a recent study that have really looked at risk factors, other risk factors as well to disentangle it.
Okay. And so do you think, will there be more trials happening that include Black Americans? And, is it, how do researchers go out to high risk groups to see?
Absolutely. So we're starting to do those studies. So I mentioned a large study that I'm leading that's doing the first step for gene-based studies, also looking at risk factors in them, but we absolutely need to enroll and recruit, enroll and capture more families to be part of research so we can identify these differences. This is bringing together all these sites, and individually, we don't have enough to really understand and disentangle patterns, but collectively bringing together, we're starting to understand it. But compared to other populations, European-based populations, we have 1,000 African Americans cases and controls in this study. And that was because that was all we could get. It wasn't that. And so it's really a first step in the process.
Sure. And I applaud you taking that step. Another specific question is in vitro fertilization and preimplantation genetic testing an option for detecting pancreatic cancer?
For detecting it or for these genes? I think that's a question I would always defer to a genetic counselor, and something you should discuss with them regarding decisions for you and your family.
Okay. Mm-hmm. What are your thoughts on DNA banking?
So DNA banking for, it is always an option for families to kind of understand this and to get to bank DNA on their family member to kind of understand this. There is a lot we kind of don't know. And as we see now with these, where it could be useful is in the situation we talked about earlier, where there is kind of a highly aggregated family with pancreatic cancer. If there was DNA on the patient, then you would know whether that patient had an inherited mutation or not. If that patient did have an inherited mutation, then you would know which of their children are at risk and which aren't at risk. Whereas now we kind of don't know. As we understand genes kind of at the population better, or identify more predisposition genes, hopefully we can go to each patient and each individual and understand that better without that other family member to kind of provide more information. So it is useful. It's not free. It costs money. So I think, again, it's a very personal decision.
Sure.
Mm-hmm.
Do you think that pancreatic cancer research will catch up to some of the other cancers?
I think it will. I think we have, we understand it very well, kind of genetically, kind of the basic science of it, the development of it. We're constantly learning things. And I do think we know a lot about it. It's just, it is challenging because we see very small tumors that kind of spread and metastasize. It's an internal organ. It doesn't present with signs and symptoms until the disease is often at a later stage. And so, we just have a lot of challenges, but we are still, we've come a long way. We still have a long way to go. But, we have seen kind of tremendous strides in the past 10 or 15 years. 30 years ago, it wasn't considered a genetic disease. And now we have germline genetic testing recommended for all newly diagnosed cancers. And it was one of the first cancers to do that. So we've come a long way.
Okay. Another one just came in. From your perspective, what's one question that people never think to ask, but's important to know regarding pancreatic cancer and genetics?
That is a tough question. I don't know. I mean, I think to me, I think asking the question about family history and genetics, it's often not asked. And I think it should be and part of the conversation. I would say it's not the question that's, I think that's the one is we don't, it's often not considered, or it wasn't often considered as part of the thing. And we still hear often that, pancreas cancer isn't genetic. So it doesn't mean that it's, it's thought to be that about 30 to 40% of cases might have a genetic basis. So it's not all, but it's important is those. And I think it provides, I think it's helpful, and understanding it is helpful, but also, if we can, it's where we're going to start to see early detection first. If we can detect and intercede in these high risk populations, then I think we can move it to lower risk populations once we're able to do it better and balance the risks and benefits.
Sure. So what are the top 3 items that you think that you want viewers to take away from tonight? Because obviously, again, you shared so much great information here. What are the top things that you want to know or to do?
I think understanding both the importance of kind of knowing the genetic basis of pancreatic cancer, knowing the limitations of it, and also kind of where there's hope in terms of screening and early detection.
Well, great. Well, thank you so much. This was really interesting on so many different levels, and judging by the questions that were coming in, our viewers were really getting a lot out of it. So thank you, Dr. Klein.
Thank you
for the work that you're doing and continuing to work and to do and to lead. It's really needed and much appreciated.
Thank you so much. It was great.
Thanks. And thank you to everybody who's joined us tonight. If you're catching the replay, please be sure to write replay in the comments and ask your questions so we can be sure to get those off to Dr. Klein and get back to you. And keep an eye out for next month's Wellness Wednesday. We're going to be announcing the program and date shortly. And if you have ideas for future Wellness Wednesday editions, please be sure to comment below, or you can email us directly at info@ralphfoundation.org. Finally, we're getting ready for November's Pancreatic Cancer Awareness Month with lots of great activities and information, fundraising ideas, and all of that's going to be coming out very soon on our social media channels, on our website. So keep an eye out there and get ready to get in on that. On behalf of everyone at Ralph Pancreatic Cancer Foundation, we thank you all for joining us tonight. Again, thank you, Dr. Klein. And I hope that everybody has a good evening, that you continue to do your part to stay safe out there. And we look forward to seeing you back next month. Until then, take good care. Good night.